In terms of brain tumors, we have both central brain tumors in terms of gliomas, more benign tumors in terms of meningiomas, and then there's the metastatic disease. So we go through a potential of metastatic melanoma. So this presents as primarily a skin lesion, but can travel to remote sites in terms of secondary hematogenous spread. So you can see here's the local like skin manifestations, but a lot of times this can infiltrate through the bone and into like the brain itself as well. And these specific tumor types are prone to hemorrhage. Can metastasize to lung, liver, skin, intestines. There are primary brain tumors, as we can talk about as well, that have potential mechanisms in terms of neurotransmitters. And ultimately, this can lead to a host of disease manifestations. There is emerging treatments in terms of immune therapies, but ultimately, in regards to more of the headache management and more of the systemic management, that's where a role of potential psychedelics can go into play. As we mentioned, these checkpoint inhibitors have been very vital in terms of overall improvement of survival for these patients. And then there's ischemic stroke where you have disruption of the blood-brain barrier. This can cause severe edema. Patients often are presenting with aphasia, difficulty speaking. They have some weakness. We can do mechanical thrombectomy, but oftentimes the long-term recovery process is delayed as well. This can cause disruptions in neuronal function, astrocyte function, the brain immune cells in terms of microglia, in terms of cytokine release, and then endothelial cell disruption in terms of that blood-brain barrier. There's emerging treatments in terms of protein kinase C modulators that have shown some effect. But the main other etiology is epilepsy, which has glutamate excitotoxicity. This can cause sclerosis, can contribute to some of the tauopathies, really targeting more of these NMDA receptors, which we'll go into in terms of potential role for the psychedelics as well. And the ketogenic diet has been shown to alter some of these ion channels and have been beneficial for these patients. So what are some of the limitations for these neurologic injuries? Inadequate pain control, poor modulation of behavior, lack of targeted treatments and therapeutics. So we'll dive into more of the psychedelics now. The neurologic and psychiatric pharmacology fields have grown immensely since the 19th century and have brought considerable benefits to managing and treating various illnesses. For example, the introduction of morphine, as well as other medications that induce sedation for the rapid control of agitation and aggression in psychiatric hospitals during the second half of the 19th century really sparked research into pharmacotherapeutic interventions for neurologic and mental health illnesses. By the late 1950s, the discovery of 6 different central nervous system neurotransmitters, acetylcholine, dopamine, GABA, norepinephrine, serotonin, and substance P, allowed the development of pharmacotherapeutic treatments for neurologic conditions such as Parkinson's disease and psychiatric conditions such as depression and schizophrenia. In contrast, there appears to be less interest in the research and development of psychoceutical drugs within the 21st century. The current state of psychoceutical intervention has remained motionless for a long time. Many of the drugs within this class used today were discovered more than 70 years ago. Various factors that surround the research and trial testing of psychoceuticals have kept the development of these drugs from moving forward. Some examples are the limited pathophysiological knowledge, high rates of failure in phase 3 trials, poor predictive animal models, later returns of investment and high cost of drug development, among others. These factors negatively impacted the development of new medications in this class, yet the most important one is the shift of charge from clinical research to the pharmaceutical industry. Clinical researchers are restricted in supporting pharmaceutical interest, which can increase the risk of bias. Such restrictions of data to the pharmacotherapy community can potentially harm the patients these products are intended to treat. Therefore, it is really important and critical to monitor the development of novel psychoceuticals that aim to replace or improve pharmacotherapy in the global market. Currently, the psychoceuticals available in the global market are accompanied by multiple side effects and have response rates of less than 50%. To see a positive change in neurologic and psychiatric pharmacotherapy, the clinical research community must support the moral development of novel drugs within those fields. The main focus of developing new models of treatment should be to improve patient care management instead of supporting the pharmaceutical industry's interest. Furthermore, the pathophysiology behind the illnesses in these fields target must be further explored. So a clear understanding of the biochemical mechanism of neurologic and psychiatric conditions is key to the success of clinical drug production. Although there are other issues at play, we will tackle some of these emerging psychoceuticals and the way that they have improved over the last couple of years. We target the 20 most common drugs that we will address going forward. Here's a little bit more about that mechanism of action. As mentioned, opiates have been a primary stay of treatment, and these are targeting specific beta-arrestin pathways, especially through K-opioid receptors, serotonergic receptor targeting drugs that promote more of this robust serotonergic pathway, 5-HT receptors, and the blocking of the reuptake of serotonin are potential targets. As mentioned, especially for the epilepsy population, the MMDA receptor targeting drugs act as antagonists and inhibit the receptor's activity. So in going through the data, we looked through over 105 different published studies, really trying to nail down the key mechanisms at play. So we'll dive into each of the drug compounds and how they work. The psychoceutical list is composed of drugs with various CNS targets. Most of the drugs target the serotonin receptors, followed by drugs that target NMDA and opioid receptors. Other targets include GLU8, NF-kappa B, alpha-3, beta-4 receptors, GABA receptors, and peptides. It is essential to recognize that not all the biochemical pathways of these drugs are fully understood at this point. Of the 20 drugs that we will review, 9 target serotonin family receptors, 2 interact with opioid receptors, and 2 interact with NMDA receptors. 2 drugs target all 3 types of receptors. The other 5 drugs interact with one of the remaining targets. In general, serotonergic targeting drugs directly enhance the activity of these receptors or increase the serotonin levels in the synaptic cleft by blocking reuptake transporters. Opioid targeting drugs increase the activity of the G protein signaling and other pathways, such as the beta-arrestin and ERK-MAPK pathways, and MDA targeting drug acts as antagonist. So we'll dive into a little bit of the mechanisms now. The first drug is the 5-methoxy-NN-dimethyltryptamine. This drug acts as a serotonergic analog in the serotonin system and has high affinity for the 5-HT1A receptor, potentially being a novel treatment for depression, as well as some of the behavioral manifestations associated with traumatic brain injury and potentially subarachnoid hemorrhage. The DMT activates pharmacologic receptors such as serotonin receptors within the synaptic cleft after its secretion as a neurotransmitter. The exact molecular characterization is still unclear, but it is currently being tested both for depression as well as some of the ongoing anxiety responses associated with neurologic injury. MMDA is well known. It's a derivative that acts through the release of serotonin as well as norepinephrine, blocking their reuptake within the synaptic cleft. At this point, primarily preclinical studies are being done for further investigation. LSD functions to increase serotonin concentration and acts at the 5-HTA1A and 5-HT2 receptor agonist. It has inhibitory effects upon the 5-HTA1A receptors and stimulating effects upon 5-HT2 receptors. Modulations of this treatment are being investigated in terms of stroke management. Ongoing trials are still upcoming. Peyote or mescaline is an active component of peyote. It functions on the serotonin receptor agonist, specifically on 5-HT2 receptors, has a high affinity for the C receptor as well as the A receptor. It increases the cytosolic levels of IP3 through GQ coupling of G proteins and stimulates calcium channel opening. This has potential mechanisms for some of those epilepsy-related treatments as well as subarachnoid hemorrhage. Further work is ongoing. For the psilocybin analog, this converts to psilocin. It functions as a partial agonist of 5-HT2A receptors. What's interesting about this compound is that it could be potentially modulated to decrease dosing concentrations, which could have clinical efficacy. The deuterated DMT acts as an agonist for 5-HT2A. Uptake of DMT occurs through serotonin uptake transporters, and it's sequestered into synaptic vesicles. The phenethylamine derivative inhibits serotonin as well as dopamine and acts within the synaptic cleft. And then the psilocybin, as we had mentioned with the analog, functions as an overall agonist of 5-HT2A receptors and acts on G protein coupled receptors. We have ketamine, which is the most well studied at this point, specifically for resistant depression, and can have efficacy for neurotrauma patients as well as stroke patients. It functions in a different mechanism with the NMDA receptors. It acts as an inhibitor with long-lasting effects. Metabolism is to H and K. Particularly, it has strong benefit in preclinical and clinical studies. Different formulations are being investigated for rapid administration. SLS-002 functions as an antagonist as well to the NMDA receptors. It also has binding affinity to GABAergic interneurons. A glutamate surge follows, stimulating AMPA receptors to potentiate BDNF and mTORC signaling pathways with a potential role in more long-term stroke recovery. Kratom is an opioid receptor. It acts on the mu-opioid agonist with the ability to interact with G protein coupled receptors. It has strong analgesic effects, potentially offering a role for headache management. Salvinorin A is an agonist of kappa opioid receptors and is coupled with GIO proteins. It inhibits adenylyl cyclase and has specific role in the ERP MAPK pathways. Ibogaine functions as a kappa opioid receptor agonist. Also has effects on NMDA receptor antagonist, serotonin uptake receptor antagonist, and nicotinic receptor antagonist. Going more to the dual channeled agents now, the neurobogaine has a effect on NMDA. It's a metabolite of ibogaine, has effect on the mu opioid receptor as an agonist as well. SLS005 is a GLUT8 receptor. It stabilizes proteins, enhances autophagy, enhances lysosomal pathways. So really showing some benefit for when that potential blood-brain barrier disruption occurs post-stroke. Along the same lines, SLS007 is a peptide. Doesn't quite cross the blood-brain barrier, but in areas where there is disruption, such as subarachnoid hemorrhage, can have some beneficial effects in targeting that lymphatic pathway. N-acetylcysteine targets glutamate receptors. It increases intracellular glutathione, has neurotrophic and inflammatory regulatory responses. And MM110 targets the alpha 3 beta 4 receptors. It inhibits nicotinic receptors and ultimately regulates dopamine levels during withdrawal. Could also have a potential role in headache management. And intoxin D3 is also a deuterated agent. It targets GABA channels. It can increase mitochondrial translocation as well as stimulate neurosteroid synthesis. So we'll go into a little bit of the clinical data before diving into some of the conclusions at this point. So most of the psychoceuticals reviewed fall into the large category of the serotonin pathways. These drugs generally bind to the G proteins within the serotonergic pathways, multiple different targets, 1A, 2A, and 2B, and they act agonistically. Additionally, two of these, ecstasy and CYB005, block the reuptake of serotonin, increasing serotonin levels within the synaptic cleft. These drugs increase the activity of serotonergic systems within the CNS. Although these drugs are expected only to stimulate serotonergic systems, LSD demonstrates an opposite effect. It has dual effect on brain systems such as the locus coeruleus, raphe nucleus, and brain cortex. The agonist activity on serotonergic pathways has inhibitory effects. In contrast, the agonists act as 5-HT2 receptors and stimulatory effects. No reports of the other 8 drugs within the serotonergic pathway show a similar response. Underlying mechanisms activated after the drug receptor interactions have still not been fully confirmed in terms of the 9 psychoceuticals. Research on peyote activity has revealed that the T2 receptors, especially T2C receptors, and their associated G proteins activate phospholipase C. Activation increases the cytosolic levels of YP3, causes endoplasmic reticulum release of calcium and postsynaptic neurons. And maybe assume that these type of drugs initiate cellular mechanisms similar to peyote, but they cannot be guaranteed at this time. LSD demonstrates very strong selectivity for the beta-arrestin pathway, one of the key pathways that we had showed in that first schematic. And with the nature of some of these neurologic injuries with CNS enzymes that can denature some of the serotonergic systems, really show that there can be improved efficacy. The active metabolites can have very profound restorative effects instead of the non-injured state where they primarily act as endogenous hallucinogens. serotonergic transport blockers give another option to affect CNS serotonergic system activity indirectly. They really focus on that synaptic cleft. In terms of the NMDA receptors that we targeted, those specifically are looking at both the regulation in terms of effect on depression, with ketamine having the most robust data and having increased clinical usage. Underlying mechanisms of how ketamine is fully processed is still being investigated, but the upregulation in terms of AMPA receptors is promising as well, specifically for BDNF and mTORC1. That has been shown to be efficacious specifically for some of the agitation responses. In terms of some of these novel opioid receptor targeting, such as salivinorin A, really focused on mechanisms of G proteins that have potential benefit on atypical pain control, with at least a lower profile for addiction, with increased activation in terms of managing overall pain symptoms. These compare very favorably to other opiates with much lower addiction rates compared to morphine or some of the more classic opiates. They also have potential decreased lethal side effects and can be a good transition for patients suffering from long-term opioid use. And in terms of the multi-receptor drug targeting, these anti-addictive effects that are present with the kappa opioid receptors is beneficial in terms of pain control without the ongoing dependency. They can actually have some acute exposure for sensitization and then can be weaned off quickly. In terms of their ongoing roles, they're being very actively investigated. We're also looking at other receptor-targeted drugs. These are specifically focused on more of those group pathways, the N-acetylcysteine, some of the levels in terms of GABA modulation too. Specifically with some of the combinations with the ketogenic diet that was discussed for epilepsy can have some potential benefits. These studies have primarily been within the preclinical space, but some are advancing now to clinical trials. So in terms of clinical uses, LSD has been investigated in terms of treating chronic alcoholism and anxiety. MEO-DMT has found fewer suicidal thoughts and plans, as well as attempts. Ibogaine has been able to reduce cravings, both in humans as well as in rodent models. MM110 has mitigated symptoms of opioid withdrawal. CYB004 has treated neuroinflammation and psychiatric symptoms, specifically offering a role for neurotrauma, as well as some of the stroke patients. CYB004 has been shown to have strong effect on general anxiety disorder. Peyote improves depression and anxiety. Deuterated etoxaphene has been used to treat anxiety. Salivinorin treats overall sense of panic and distress, can induce a sense of feeling calm and relaxed for patients. There's improved functional outcomes following TBI for SLS005. Psilocybin reduces depressive symptoms. Ketamine, as we talked about, has anti-inflammatory as well as antidepressive roles. And then the kratom is a substitute for opiates that has been studied. So these are really emerging as treatments. There's a lot of ongoing investigations, a lot of are advancing into phase 3 that's extending well beyond our initial understanding of the pathophysiology. There'll be more and more treatments that are coming to market. The 20 psychedelics that were presented here show the strongest preclinical and/or clinical promise. Many of these drugs, in terms of mechanisms and side effects, still have a long way to go in terms of investigation. A lot of ongoing studies are in phase 2 and phase 3, hopefully advancing to phase 4 with long-term monitoring going forward. But in terms of overall treatment effects, really focusing on headache management, really targeting the behavioral control both from anxiety and depression, and ultimately really trying to improve the outcomes for patients. And so, with that, I would be happy to take any questions. You can put them in the chat box, and then I am happy to answer from there. Is there any questions? So great question about will they be safe for children? At this point, they are primarily being investigated for adults. There are a lot more regulations in terms of FDA management. I think the first agent that will probably be investigated will probably be ketamine and its derivatives in terms of treatment for teenage patients at this point has advanced to that point. Will likely advance in terms of pediatric management for severe brain injury as well. But that will probably be the first agent that gets further investigation within pediatric population. At this point for the psychedelics, they are in phase 2 and phase 3 trials. The ketamine is actively approved at this point for treatment-resistant depression, so that's passed through phase 3. Um, some of the other ones are currently being investigated. I anticipate probably 24 and 25 for most of the clinical trials that are being reported is when we'll have some of the data from some of the further agents. Uh, I anticipate at least 2 or 3 additional will probably be approved by that time. So I want to thank everyone again for coming and listening today. If you want to email me, you can email me at brandon.luckewold@gmail.com. And again, make sure you sign up for MD4Lives for all of the great information that is shared there and ability to participate. But I appreciate all of you for coming and listening today.